Good evening and welcome, everyone. Please, I think most of you have, but if you haven't, there's some food and drink over at this side of the room, and please help yourself throughout the presentation if you want to get going. But hey, first and foremost, thank you to you and for those who are online listening in, because you're all interested. You're interested in learning more about our cardiovascular system and what it can do and what we can do to help minimize some of the diseases. And for that, I really congratulate you for taking the time to be here. And I have to say, I'm excited. My name is Ruiz, and I work in business development at MemorialCare Long Beach Medical Center, and I have the great fortune to work with our speakers for this evening. Dr. Fernando Mendoza is our first speaker, and he serves as the medical director of non-invasive imaging, which is echoes, and cardiac rehabilitation, and he also serves as the chair of the cardiology department at Long Beach Medical Center. He is definitely a Southern California man, having done his medical school at UCLA and residency and fellowship at Cedars. So we are very happy to have him. And then afterwards, Dr. Christina Rodriguez Ruiz will come up. And she is originally from Puerto Rico. She did her medical school there and then came here and did 2 fellowships, the first at Scripps down in San Diego, and then the second one up at Stanford. And so she serves at Long Beach as our medical director of advanced cardiac imaging. And some of this is really new, and so I think you're really gonna enjoy it. So without anything else, more from me, please write down your questions as well. We will have a great Q&A afterwards. And I think you're really going to enjoy this evening. So with that, Dr. Mendoza.
Okay, you guys can hear me okay? Okay, perfect. All right, so first of all, thanks everyone for coming. I hope you enjoy this. I was asked to put this together about a month ago, and I said, prevention's, I talk about prevention in my office every day, but putting together a presentation on prevention, it's not the most exciting topic. So I try to do something a little bit different with it, and hopefully it sends the message home, and I'm definitely available for questions afterwards, okay? So let me see, I have my slide thing here. So, all right, so that's me. All right, so instead of going straight to prevention, what are the things that we can need to do to prevent heart disease, I thought I would spend a little bit of time on talking about what we're preventing. So sometimes if you understand what we're preventing, that may give you send the message home a little bit better, okay? So, I know a lot of people some people know what a heart attack is, not everybody does, right? So what is the process of having a heart attack? So if you can, take a look at the slides, on the left-hand side, you see an artery, and the yellow stuff is cholesterol that's starting to bind to the artery. And then in most people, that kind of builds up over time. And then eventually what can happen is if you take a look between the cholesterol and the artery, where your blood flow is going, that's the white part in there, is a little layer of skin. Some of you guys can see that. That's that little, right? It's called endothelium. So sometimes just as the blood flow is going through that artery, that skin can break, okay? And then you have what's called a plaque rupture. So just like if you get a cut in your skin, what happens, you bleed and you form a scab to try to fix that skin. Well, if you get a cut inside of your artery, your body tries to heal that, and it does that by forming a clot, but sometimes that clot closes up the entire artery. That's a heart attack, okay? It's your body trying to basically cut a little cut in the skin, okay? So that's one form of heart attack. That's the kind where you can literally, and that can happen from somebody who's got a blockage that's only 5 or 10%, or it can happen in a blockage that's 70%. That's why, in theory, somebody can literally be exercising and run a marathon one day, and then the next day they have a heart attack because that blockage wasn't there 70% the day before. They just happen to have a random event, which is a cut in their skin as the blood's flowing through there, okay? So that's a heart attack. That's the main heart attack that you feel suddenly and it kicks in. There is a second type of heart attack where you just have a blockage that's so bad, maybe 70% blocked, 90% blocked, and some kind of stress happens to you. Maybe you get a pneumonia, the stress of the pneumonia causes you to have a heart attack, or little by little, you start having more and more chest pain to the point that even walking 5 yards gives you chest pain, and then that's a different kind of heart attack, okay? So 2 main things. So the ones, all right, and then, okay, so there's some interesting stuff. So we know that when people start getting cholesterol, your body's arteries, the arteries inside of your heart, can adapt pretty tremendously. Like if you take a look at that picture on the top, that's somebody who little by little is getting blockages in their arteries. But if you actually look at the area of the white, it hasn't changed. So as this person builds up cholesterol, the artery gets bigger to dilate to try to keep that artery the same size. That's why if you do an angiogram, and I'll show you what an angiogram looks like in a minute, you may not see any of the blockage, even though there's tons of blockage already. You can see this artery's got a ton of blockage. It's almost the same size as somebody who's got no blockage at all, right? So that's called remodeling. That's something that happens to everybody's heart, right? So this is and then so as the cholesterol kind of builds up in your body, and sorry, I'll go back and forth in between both sides. So the pictures on the bottom, you can see some of them have a lot of cholesterol. That's the yellow stuff. The one on the right doesn't have any yellow. That person's arteries, at one point they had cholesterol, but it kind of just scarred up, and it's something what we call more a fibrotic plaque. Those are less likely to rupture. The ones that have the cholesterol and that lipid pool are the ones that are more likely to rupture. Okay? And then the white stuff is in there is calcium. We'll talk about that in a minute. Okay? All right. So if you take a look at this picture, I'll come on this side here a little bit. So this is a person who had an angiogram. And if you could take a look at the picture, there's a couple of markers there that tell you at certain points along the angiogram what's going on. So, for example, on the right, those 2 arrows are the same person, and you can see there doesn't look like there's a blockage in that artery, right? But if you look on the gray, this little thickness here, okay, that is cholesterol buildup that's inside of there that you can't see on an angiogram. And you can see things, you can put an ultrasound down someone's artery, and in this case, what you see is the green stuff is the cholesterol. Again, if you just saw the angiogram, you wouldn't even see it. You'd think there was no blockage there, okay? So knowing those things, so again, heart attacks are caused by cholesterol that builds up. It's basically some of them basically turn into scar tissue. Those are less prone to heart attacks to rupture. Some of them are prone to just stick with the cholesterol, and then eventually some can rupture eventually. All right, so what is congestive heart failure? That's another thing that we try to prevent in heart disease. So I think a lot of times people have heard lectures about trying to prevent heart attacks, but this is an equally important disease state that I think kind of doesn't get talked about, especially at a lot of community events. And a lot of people don't even know what congestive heart failure is. So usually we divide congestive heart failure into 2 types. One is where your heart is just too stiff. From whatever reason, some of it is aging, it just loses its elasticity. So as the blood comes through the body and it tries to fill up with the blood, the heart is just so stiff that the pressure's high, some of that fluid backs up into your lungs, into your legs, et cetera, okay? And then another type is where the pump actually is not pumping as well as it is. That's systolic heart failure. And if you look at the amount of money that Medicare spends, of all diseases, every disease that exists, congestive heart failure is actually the number 1, okay, spender. So more of an issue than even the heart attacks and stuff like that that everybody knows about and talks about preventing. So here's a couple of heart ultrasounds that show the form of congestive heart failure. You can see the one on the, I guess if you're looking at this screen on your right, you can see that one doesn't seem to be pumping as well as the one on the left, right? That's the systolic heart failure. You can see how the one on because the amount of black kind of gets, the one on the right, you can see that there's a good squeeze, right? But you can also see that muscle's really thick, right? So that muscle's really thick, and so it loses its elasticity. It's harder to fill. So it's like, instead of blowing into a brand new balloon that you just got, if you leave a balloon out for a month in the sun, you try to blow it up to the same size, that's a lot more work, right? So things that cause a thick heart, one of the most common ones is just having high blood pressure that's not controlled, right? So your heart, if it has to do all that extra work and pump blood to your body because your blood pressure is so high, it gets thick, right? And then eventually there's a risk of congestive heart failure, right? If you guys have had echocardiograms, look at the heart muscle thickness, right? Sometimes the doctor may not point that out to you, But if it's thick, that's already, you're one step to getting congestive heart failure. Another common problem that's coming up, if you look at the data says that if there's about a 1/3 chance that people will get AFib at some point in their life. So if by the time you're 50, if you make it to 50, there's about a 1/3 chance you're going to get AFib at some point in your life. AFib is an irregular rhythm that puts you at much higher risk for stroke, okay? And we're going to talk about some of the stuff that you can use for prevention of that as well. Okay, so now we're going to talk about risk factors. So I think most of you guys know this, so this was part of the reason this lecture wasn't so super exciting for me. I was like, people know this stuff, right? So what are the things that put people at risk for, this is specifically for heart artery disease, so heart attacks and narrowing of the heart arteries. So what are they? So it's, genetics, obesity, overweight, having high cholesterol, diet, processed foods, lack of exercise, diabetes, high blood pressure, smoking, age, preeclampsia, gestational diabetes, things like that. There's other risk factors that maybe are less commonly known, and I wrote some of those on there, like if you have lupus or rheumatoid arthritis or psoriasis that's involving your whole body, not just your skin, those kinds of things increase your risk. Something about the inflammation that's going on in your whole body increases your risk for heart disease. If you had cancers in your chest and you got radiation, we think there may be a slightly higher risk for that as well, especially if you had your radiation like 30 years ago, 35 years ago, 25 years ago. Modern day, we use newer radiation techniques, so the risk is significantly lower, if at all. Okay? If your good cholesterol is low, and there's other things, even borderline diabetes. So some people are maybe they're excited that they're not a diabetic, but even borderline diabetes increases your risk for heart disease, as does the inflammation test that's called the CRP test, okay? All right, so, this is kind of more what I do on a day-to-day basis, right? So somebody comes in to me, sometimes they come in because they said, oh, my grandma had a heart attack or grandpa had a heart attack at a young age, and they come and see me. So this is traditionally something I would do in any given week, right? So I take a look, and we check your cholesterol, we check your blood pressure, and you can put the numbers this is something you can look up. This is it's called the ASCVD risk score. Anybody can Google this, ASCVD risk score. You put your numbers in there, and it tells you what your risk of having a heart attack is in the next 10 years. So A is in apple, S is in Steve, C is in cardiac, V is in vein, D is in disease, ASCVD, okay? Atherosclerotic cardiovascular disease, okay? So let's take a look at this person here. So this is, I put a male, sorry, maybe I should have been more gender biased, but all right. So I put a male, and he's 45, he's Caucasian, he does not have diabetes. I put him that he does have high blood pressure, and his blood pressure is 132, okay? And so when you put that information in the computer, it spits out what the odds of him having heart attack in the next 10 years. And you can see on the top right, it says 2.8% chance of heart attack in the next 10 years. So that's pretty good, right? I mean, 97% chance, basically no heart attack in the next 10 years, right? So, but if you look on the right, it tells you what their risk of a heart attack is in their entire life, okay? And that one is 50%, right? So those are conversations I have with somebody. I say, look, right now you're not particularly high risk, but if you want to do something to prevent yourself from having something in the long run, this is a good time to do it because you are high risk, lifetime risk, right? Okay, so that's one. And then I want you to look at the next person, okay? The next person is, I made the same exact blood pressure, the same exact cholesterol, same gender, same race. The only thing I changed was the age, 68, okay? And you can see that now the risk of heart attack in the next 10 years is 20%, okay? Almost 10 times as high, okay? That's for the same blood pressure for the same cholesterol, right? So sometimes people come to me and they're confused. They're like, I've had cholesterol my whole life. Why do you care about it now, right? As a doctor, I don't treat labs, right? I treat people and I treat risk, right? So this is the message. So I don't, if your risk is low, I'm not as worried about it. But at some point, your risk is high enough, we got to do something about it, right? And so, and that's, we'll go over diet, we'll go over exercise, and we'll go over medications. It's pretty powerful what diet, exercise, medications they can do. I mean, they can often reduce that risk by more than half, right? So, if you're 2%, maybe you can probably get away in the short run not doing all the things you're supposed to do, but like I saad, the lifetime risk is high, whereas if you're already 20%, that's considered high risk for a heart attack, okay? You bet time to do something's now, right? Because you're at high risk, okay? So again, my job is not to do plastic surgery on your labs. My job and make your labs look good is to assess your risk and to treat that risk, right? Okay, all right. So here's another thing that we can do. Dr. Rodriguez is later on going to talk about a coronary calcium scan. This is a nice tool that I like to use. So if you put in like the same exact numbers that I just put for the cholesterol, blood pressure, all that stuff, and you just add a coronary calcium score, that's a CAT scan that's pretty cheap. Insurance rarely covers, but you can pay cash for it. And a lot of, if you're sorry, I'm going to backtrack. If you're Medicare covers it. If you're not Medicare, they don't usually cover it, but it's usually at most like $250. There's some places sometimes you can get it for $130, things like that. Okay? So this person had a calcium score of 20, which is not super high. I mean, I've seen people with scores of 4,000, right? So this person, if I put that in, and again, another website you can go to if you decide to get this calcium score, it's called the MESA 10-year CHD risk score. You can see it there. Take a picture of the slide if you want. You put your calcium scan in, you put on all those numbers, and it tells you what your odds of having a heart attack is. So it turns out that when we put his in, his risk of a heart attack in the next 10 years is actually 7%. So if I didn't use that test, I would have thought that person was low risk. And so his risk is actually 3 times higher than what when we thought it was, just based on the calcium score, okay? All right, so I use a lot of calcium scores, okay? In part because, and so one other thing, like if you look, you can actually figure out what age your arteries, you can do some statistics and you say, so he may be only 45, but his arteries are the age of a 64-year-old, okay? Because your average 64-year-old has a score of 20, right? So he on the outside, okay, he may be 45, but his insides are 60, in the 60s, okay? There was an interesting study done in the 2000s, and it looked at, not this calcium score, but the step right before this. How good is that for young people? And it turns out it's not super great, right? Which is why I get a lot of these calcium scores. So typically I'll consider calcium scan on a man over 50, man, usually at the youngest, like 50, woman, like 55 or 60, because women tend to get their disease about 10 years after men. And so they did a study and they said, let's look at everybody who's males under 55 and women under 65 who came into the hospital with a heart attack. And let's review their labs that they had in the last year. How many of them would have been recommended to either go on a medicine or do something because their risk for heart attack was high? Only 25%, right? So without the calcium scan, we miss 75% of the younger people who are going to go on to have heart attack. That's okay. So again, it's not that first scan is not as great for the young people. It works really well for older people. And the main reason why is because when young people have heart attacks, they don't have the ones where you progressively narrow, right? They have the kind where you rupture from a 5 to 10% blockage, right? So that can be me, right? I could have a little bit of cholesterol and I could have a heart attack. And, if I don't do good tonight, maybe I'll have it tonight or something like that, right? So anyway, that's the idea, right? So it doesn't take a lot of plaque in your arteries to have your heart attack when you're young, but it happen later on. All right, so what do we do? So what if you are high risk, or you just, even if you're low risk, but you want to do anything you can to prevent it, maybe because it's in your families, or maybe that's just your nature, right? So a lot of this are things that you guys mostly know about, right? A lot of it is diet, right? So, and the 2 diets that have kind of been best studied for showing that they can reduce heart disease are, Mediterranean diet and the plant-based diet, okay? And I mean, giving a lecture on Mediterranean diet is like an hour lecture on its own. So usually I tell people, go to whatever bookstore you use or Amazon or wherever and buy a book on Mediterranean diet. It's a very doable diet. And buy it as a resource that highlight all the important pages, because if you're like me, you read something and 4 months later you forgot 90% of it, right? So fold the pages. There's Mediterranean recipe books. There's all kinds of things that you guys can find, okay? Plant-based diet works very well as well. A lot of people have a harder time doing that kind of stuff. So I think the Mediterranean diet is more doable, but anybody can do, those are the best, okay? And exercise, every little bit counts. I mean, I think sometimes people think that they have to go on a treadmill or on a bicycle. You know, honestly, even walking is tremendously powerful, okay? So do everything you can. Smoking cessation, you know, weight loss if you're overweight, obese, blood pressure control, diabetes control, cholesterol management. And all right, so again, I thought, you know, a lot of times also what I thought I would do with this lecture is a lot of times, you know, in medicine, we all kind of work in our little silos, right? The cardiologists know cardiology and only talk about cardiology, and the brain doctors talk about brain doctors, and the cancer talk about brain doctors. But what I thought I would do is just talk about how much overlap there actually is in these risk factors between all these disease states, et cetera. So just looking at heart disease and congestive heart failure, we talked about how congestive heart failure is the number one thing that Medicare spends money on, right? So look at all the overlapping risk factors, right? If you're overweight, obese, you're more likely to get heart failure, more likely to get heart disease. If you have high blood pressure, it increases your risk for both. Physical inactivity, it increases your risk for both, okay? So they're very overlapping, okay? And then in fact, one cause of congestive heart failure is heart artery disease. So pretty much anything that has heart artery disease is a risk factor for congestive heart failure, okay? What about AFib, right? We talked a little bit about AFib, right? What are the risk factors for AFib? Well, sedentary lifestyle, tobacco, high blood pressure, obesity, diabetes, sleep apnea. Almost the same, right? Okay? And we talked about the incidence of getting AFib, that, you know, if you make it to, if by the time you're 55, if you're still alive at 55, you got about 37% chance of getting AFib in your life, right? And AFib increases your risk for heart disease. And even though there's a slightly higher risk for, of AFib in males and females, AFib is a lot more pathological in females than it is in males. So you definitely don't want to discount females here. And in fact, I think females should often be treated more to prevent it because there's more risk for, you know, future valve disease, et cetera, right? So it is a disease of mostly older people. So majority of people, as you can see there, 80% of people who have AFib tend to be over 65. So I have this slide here. So this is one quick prevention thing, and we may even be able to prevent a stroke tonight. So if you have an Apple phone, okay, make sure that you have your AFib detection setting on, right? And this is what you would do. Sorry, if you have an Apple Watch, okay? So you would go to your phone and find the health app, and then on the bottom right, there's a little thing called browse. If you just take a picture of this, if you have an Apple Watch, you can do it at home, okay? And then hit the browse button. After that, you're going to hit the section that says heart right there in the middle of the screen. And then when you hit that in the middle of the screen, there's a button there that says irregular rhythm notification. You hit that one will set it up so that when you wear your watch, it's constantly looking to see whether you have AFib, okay? I've had, you know, it's amazing to me. I see people come into my office, anytime I see them wearing a watch, you know, I obviously have a lot of people who are over 65 who aren't tech savvy. If I see them wearing a watch, I'll grab their phone, I'll turn it on for them, okay? I would say about half the people don't even have it on, right? So we can prevent some strokes here with this, okay? If you have a Fitbit also has some EKG detection, so it's not specific to Apple Watch, and there's Oura rings now as well that can do some AFib detection, right? Not everybody knows, some people don't feel their heart when it's beating irregular, and so that's the value of the watch or the ring, because it'll tell you when you're having AFib, okay? Some people know when they're in AFib. Okay, so this is the part about the silo. Okay, what are the risk factors for dementia? It's almost exactly the same ones as the risk for heart disease, right? Okay, high blood pressure, right? Diabetes, right? Physical inactivity, being sedentary, right? Almost the same exact things, okay? And what are the risk factors for stroke? Almost the same exact things, right? What are the risks for cancer? A lot of the overlapping ones, right? In fact, they've done studies that said if every woman walked a moderate amount, okay, that we would have 15% less breast cancers in the United States, okay? So if you're not gonna do it for your heart, do it for your brain, do it for your cancer, right? So the same thing that you're doing that can prevent your heart attack is gonna prevent so many other things, right? And so maybe, you do something and maybe you're like, who cares if I have a heart attack and die? That's not a bad way to go. I've had people tell me that, okay? I beg to differ, but I've had people tell me that. Well, I mean, the same thing's gonna prevent all these other things, right? So do it. If you're not gonna do it for your heart, do it for these other things, right? So what are the role of medications? So when we, an ideal world, right, we do all this stuff with lifestyle, what we call lifestyle changes. That means eating healthy, exercising, getting out there regularly every day and doing those things. But there are some people that, they've already have so much cholesterol buildup in their arteries that, I mean, even if they change their diet radically and they change their, and they exercise radically, they've kind of waited too long. And so that's a role for medications, right? Or, some people, just for whatever reason, they can't do it. Some people have chronic back pain and they can't exercise, chronic knee pain, can't exercise. Some people are just not in their DNA, right? That they're just not exercisers and things like that, right? So in those cases, the medicines are there when you can't do things with your diet and exercise, right? So, and we'll go over some of those medicines in a little bit, okay? And then, sometimes treat because you have other disease, right? So if you have diabetes, we're not just treating your diabetes to prevent heart attack, but also to prevent, dialysis, peripheral artery disease, other things, blindness, things like that, right? So, cholesterol is really prevalent in the United States. So, they said about 345 million people are in the United States when this slide was made. And about 60 million meet the criteria to be on cholesterol pills. Okay, so that's a lot of people, right? And mostly the people that are on the older line. And typically we'll use statins first line. We'll talk about that in a little bit. So that's a lot of people. And I know there's always a little bit of hesitation to go on medications. But again, I talked about how in an ideal world you do it with diet and exercise. But in the cases when you do need medication, there's a role. And statins are typically the ones that we use the most. And so many times I bring this up every day and everybody's like, oh, I've heard so many bad things about the statins, right? And it's true because, if you got, 60 million people taking these things and, even 5% get muscle aches with it, that's a lot of millions of people complaining of muscle aches, right? So, but the 95% who can take it without any kind of problem are having their heart attacks prevented or having their strokes prevented and things like that, right? So usually they, just because those are generic, and we'll go over some other benefits of statins. So the reasons that we use statins first, not just because of the cost, it's generic, and B, they lower cholesterol really well. But statins do things that don't just lower your cholesterol. Like we know that when you look at, we talked about how you form that heart attack when the skin ruptures, it blows up. Statins make that skin thinner and more resilient. You're less likely to get a heart attack. So in addition to the cholesterol lowering, it stabilizes that plaque. We don't know that these more newer cholesterol medicines do that kind of stuff, right? If you take a statin, your inflammation levels go lower. We don't know if the newer cholesterol medicines do that as much, things like that, right? So there's other reasons besides those. But the good thing is there are a lot of other new medicines now for cholesterol lowering, not statins, because a lot of people can't take statins. Again, probably 10% of people get muscle aches that they have to stop it, right? So that's Zetia. These all work different ways. We're going to go over the different ones, okay? But there are a lot of different alternatives. So if you're somebody who has super high cholesterol and you're super high risk for heart attacks or strokes, and you've tried a statin, you had a negative side effect, there are a lot of other alternatives. Go through those with your doctor, okay? There are other lab tests that we can do sometimes to predict whether you're at risk for heart disease or not. Like there's Cleveland Heart Labs, and there's all kinds of fancy things. I do them on occasion. I tend not to overdo them because in most cases when you order like 20 tests, 5 are going to be normal and 5 are going to be abnormal, and then 10 are going to be somewhere in the middle, right? So then, what do you do with the information, right? So instead of doing like regular cholesterol panel and then throwing this on top of that to figure out your risk better, I'd much rather just do the coronary calcium scan that we talked about, and I think Christina's going to show some pictures on later, okay? Because that looks at everything, right? Okay. And so that's it, okay? So hopefully that was of some value to you. Like I said, I'll be around a little bit later to answer some questions, okay?
So Fernando, Dr. Mendoza, talked about prevention. And so I'm going to talk about all the things that we do to detect coronary artery disease in patients, which is my jam. I love it. This is what I subspecialized in. And you might be wondering, why a cardiologist, subspecialized in almost like a radiologist kind of subspecialty. And it's because this is how I started medicine. I was really interested in finding out, being the Sherlock Holmes of medicine, finding out, getting deep into what causes disease in patients and being able to diagnose it and help people as much as I can with that information. And so when I was in cardiology in my fellowship, I wasn't exposed to coronary CT when we were training. And so I saw this picture, and of course it speaks 1,000 words, right? You can see your coronary arteries in a non-invasive manner and get to see plaque and do something about it without having a heart attack. And I thought that was so powerful. And so decided to kind of explore it further. Let's see here. And we're gonna start with a case. Dr. Mendoza gave us a lot of information. We're gonna give you a case and go through the different steps that we as cardiologists take to detect disease, okay? So this is a 46-year-old male. He presents with left arm pain, very nonspecific for cardiac symptoms. But he has a significant history of premature coronary artery disease. His dad died really early, in his early 50s. Not died, but had a heart attack, in his early 50s. So that in itself gives us some information to determine that this patient, even though he's really young, is having nonspecific symptoms, is at an intermediate risk. And I know Dr. Mendoza talked about risk, and that's how we assess these patients. If you're at a low risk, we kind of can, watch you and do some non-invasive testing. If you're at a higher risk, we might want to do some more invasive testing and get you to a coronary angiogram sooner, okay? So in this case, we have an intermediate risk patient. And our plan of attack is going to be to order some stress testing and an echo to check on this patient. And as you maybe have seen in your cardiology or even primary care visits, there's different ways or different things cardiologists use to detect disease. We have EKG, we have our echocardiogram and stress echo, which is what we use for this patient. An echocardiogram is just what Dr. Mendoza showed. It's just a sonogram of your heart. It shows us the contractility of the muscle and also the valves, and we assess different hemodynamic things with it. So it's a very useful tool for us. And then there's the stress echocardiogram. So this is a stress test, but we use imaging to aid the treadmill part. And so patients will get first an image of their heart, then go into the treadmill, and then get another image, and we can see the contractility of the heart. And finally, we have nuclear cardiac imaging. People call it a Lexi scan. I don't know if anybody is familiar with that, but it's basically a modality that is non-invasive as well. And we use a nuclear study to kind of paint the heart and see if there's any defects in it in a non-invasive manner. And then, coronary CT was there, but why do this test? Why do coronary CT? So in this case, they order stress echo. We'll get back to the case later, but in the case of coronary CT, which is what I read specifically, the 2021 guidelines had some very good news. They placed it as a class 1A indication for patients who have intermediate risk and have stable angina. Stable angina is when you're exercising and you get chest pain. So it's a really good indication for patients with that risk stratification. And the reason why we have such a high accuracy and for this test is this is a 3D model of the coronary CT. You can get it as soon as you get your pictures. And as you guys can see, if we get a good quality study, you can really take a look at your vessels, look at the caliber, look where they're arising, and it tells us so much information about the inside of your heart. And so what is a coronary CT? How do we get these pictures? So let's see here. This is my cat. People call it a CAT scan. This is Leo. So CAT scan, CT scan, those are all the same things. It's basically, yeah, he has to be there, right? It's basically when you get x-rays, we take a picture, it emits photons, and then we can process it in the computer, and we can get a beautiful image. We need contrast as well to paint your arteries and see the coronaries really well. And so for this, the heart is a moving object, and so we need to slow your heart rate for us to take the pictures. That's why it's a little bit involved. Some patients might get beta blockers or things to lower your heart rate so we can take as much of a still image as we can. And so, like I said, pictures speak 1,000 words. This picture on your left is a coronary angiogram that is invasive. And then the picture, Yeah, no, sorry. Picture, if you're looking at it on your left, is the CT scan, and then on the right, it's the invasive coronary. And you can see that we detected stenosis, so there's like this narrowing right here, and then you can look at it, it's kind of the same, so it's pretty good at diagnosing obstructive disease. And so Dr. Mendoza mentioned coronary calcium score. I mean, this is a really good tool. The difference is that we don't use contrast for this study, so it's a pretty quick way to assess if you have calcium in your arteries. But if you saw the last picture, there's no calcium, but there's still narrowing. So you can still have non-obstructive disease with soft plaque before it converts into calcified plaque, and we won't be able to detect that with the calcium score. So we'll give you guys a score. That test gives us an idea for risk stratification on patients that are asymptomatic, but then we'll perhaps miss some information that is important moving forward. And the difference is illustrated in this slide. You know, on the left-hand side, you have the calcium score, and then on the right, you have the coronary CT images, where you can get to see, hey, we detected calcium, but we weren't able to see that soft plaque, like I mentioned. And in a sense, it lets me grade stenosis. Sometimes when people get coronary angiograms, they come out, oh yeah, the doctors say, yeah, I have nothing, but they might have little stenoses. And you know, those are very important because if, like Dr. Mendoza mentioned, if you have a 7%, less than 25, or maybe a 25% plaque, that plaque might rupture and cause a heart attack. So it's important to detect it so we can then, you know, exercise harder or do lifestyle modifications or add some medication. So I just wanted to show this image to see the contrast of normal arteries. This is normal coronary arteries, your LAD, circumflex, and RCA, and then the next picture is very diseased arteries, okay? Very calcified. We can see some calcium, also some non-calcified plaque. And the importance of why we have to detect this is because patients who don't have obstructive coronary artery disease, meaning more than 70% stenosis, still have a high annual rate of dying from a heart attack. So very important to detect it, inform it to your patient, and be able to kind of act on it. And so back to our case, the stress echo and the echocardiogram were negative. We didn't find anything on that patient. This is a real life case. And so we ordered a coronary CT. And to further explain a little bit what FFR is, let me go back to the FFR CT. So this is this patient's coronary arteries at 46 years old. This patient this is the left anterior descending artery, which some people might know it as the widowmaker. You know, it's a really tragic kind of name, but the reason why we call it that way is because it supplies a really big portion of the heart, the anterior portion of the heart. And of course, if it's blocked proximally, then you can have a really big heart attack and affect most of your heart muscle, if that makes sense. And so this patient at 46 had this amount of plaque, and that's why it's so important to not ignore symptoms, right? Because this patient had a normal stress test, normal echo, and then we found this. And just to go back to that FFR knowledge, we can then send, in this case, I didn't really know when, this is a still image, and this might look really bad to you guys, but when I twirl around in my station, I can kind of see some lumen, some contrast through it, so I called it an intermediate stenosis, 50 to 69%. And so for those cases, with CT, we are able to send that to an AI-generated flow analysis, seen here with the lovely colors, and we are able to see if there is a difference in flow from one part of the vessel to the other. And that helps us to detect ischemia or lack of oxygenation in those patients. And so, lo and behold, for this patient, we sent them for invasive coronary angiography because we need to confirm this is the test that we do for diagnosing and treating patients, of course. And we found that arrow is incorrect, but it's a little bit lower. There was significant stenosis in that proximal vessel right there. And so we were able to, for this patient, he was referred to Dr. Albajota, one of our cardiac surgeons, and was able to get a minimally invasive bypass of his just LAD artery. And so basically saved his life by not ignoring his symptoms and doing further testing. And so for this patient, we have other modalities, not necessarily this patient, but everybody that comes to the door gets a CT. We not only can send it for AI analysis for the flow, but we can also send it to plaque analysis, which is something that we're getting at Long Beach Memorial soon. And what does that mean? So every patient that gets a CT, and I might say, hey, I want to analyze this soft plaque. What's this plaque made of? There's a lot of plaque. I need to know the volume. Then I get plaque analysis with heart flow. But CT is not for everybody. So who does not benefit from this test? That's why we have a lot of tests, stress testing, echo, nuclear. So patients who have a high heart rate, the pictures don't come out as well. Patients who have very low blood pressure, because metoprolol, the beta blockers, lower your blood pressure, and patients who have elevated BMI, are more on the obese side, this might not be the best test, as well as patients that can't hold their breath because we want the lungs out of the way for the test, okay? And also kidney disease, of course, we're injecting contrast into your arteries, and so if patients don't have a good way of handling contrast, then we can't do it. Stents, it depends. I've had patients who have had stents, but they should be more than 3 millimeters so I can kind of see through the lumen. And patients who have a lot of calcifications, some doctors do the calcium score, and if their calcium score is more than 1,000, then they say, I'll just send you for cath, because you might have a lot of disease. And if you saw in our last pictures, the blooming of the calcium might not let us see the disease as well. So now we're gonna go into my other modality. This is not that prevention forward, but this is when patients have heart failure already. We need to detect sometimes why the patient has heart failure. And cardiac MRI is a great modality to kind of distinguish in between what type of heart failure do people have. And so what is cardiac MRI? So have any of you had MRIs, maybe knees and stuff like that? So we take an MRI of the heart. And it is a big magnet. It's a small little hole, so some people get claustrophobia, but it's a beautiful physics. The magnet pulls all of your protons, we're mostly made of water, so it pulls all of the protons to one direction. Then we send a radio frequency pulse, it flips, and then we take a picture as it's flipping back, and we capture the frequency. I know it's very nerdy, but it's beautiful. The pictures that we take are wonderful, and the best thing of all is there's no radiation. And these are the pictures that we get with cardiac MRI. It's really impressive. You can really see the quality of the heart muscle. This is the left ventricle in all its splendor, giving it, this is a normal heart function. And so we can also detect other things. We can detect valve disease. If you have a mass inside of your heart, we can also help detect what that is. And also the most important thing, I think, in prognosis-wise, if you have scar. So going back to what Dr. Mendoza had said, when people have heart attacks, your plaque ruptures, why do we run to save your heart? Because if oxygen is not getting to your heart muscle for a certain amount of time, what happens? It dies, right? And death in the cell creates scar. And we can actually see the scar in the cardiac MRI. And the amount of scar that you have in your heart means the amount of dead tissue, unfortunately, that you might have there. But it also helps us know how to treat it. If we can't rescue that part of the heart, we might not be able to stent you or do bypass, but if we have some hope, then we can kind of get your heart going with our therapies. And so this is a picture of just the one that I showed. This is a way that we detect valve disease, so it's basically showing flow. This is a cardiac mass inside of the heart. It's basically a thrombus, which is a risk factor when patients have a heart attack. The flow is so stagnant that we might create thrombuses inside of the heart. And this is a picture of scar. That white that you see as it goes is scar inside of the heart. And this is just an illustration of how we can detect lack of oxygenation or perfusion in the heart with cardiac MRI, which is a really cool thing that we're going to be also doing in Long Beach Memorial. We can also tell you if you have edema inside of your heart, if you have early signs of fibrosis in the heart, and with tissue characterization, and if you have a really bad echocardiogram seen here on your left, you can get a cardiac MRI and really see kind of how your heart is beating. Oh, sorry, this way. Also, for COVID, you know, a lot of patients that had myocarditis, which is inflammation of the heart. We can, a cardiac MRI detects scar and edema, and so it can tell us the amount of damage that virus might do to your heart. Also, in patients that have a condition called hypertrophic cardiomyopathy, we might be able to tell you the thickness of your walls, if you have scar, and if you qualify for anything like a defibrillator or anything like that because of the cardiac MRI. This is another case. It's really fuzzy because as well as the CT scan, we do need patients to take their deep breath in and also have a good heart rate for this test as well. This patient was like I think she was 25, and her heart, the right side of her heart was super dilated, as you can see, and we detected arrhythmogenic cardiomyopathy just with the cardiac MRI. And we can do stress testing. So we found an abnormal, and how do we do that? We inject Lexiscan, which is a stress agent, while the patient is getting a scan, and we can detect perfusion defects. And this is an example of how we detected multivessel coronary artery disease with the stress test. And coming up with, in our facility as well, once we do the stress cardiac MRI, we will be able to detect microvascular disease, this is especially prevalent in women's heart disease. But before I finish, I think this is my last slide, and this is kind of things that we do at Long Beach Medical Center. I just wanted to say something about prevention. You know, these are all modalities that help us treat and prevent disease, but it's so important for you guys to do this, you know, in an early fashion. The earlier we prevent heart disease, the less chance you'll have of having a heart attack. By doing anything you can do. I tell my patients, even if you can have a little weight in, you know, one of those wrist weights, or in your ankles while you're doing the dishes, whatever you can do to kind of exercise and push your body a little bit, you're gonna thank yourself later, because, you know, we want to prevent all of these diseases and definitely be as healthy as we can. So exercise, eat healthy, and you'll be okay, hopefully. Thank you. I think that's all.
That was pretty impressive, Dr. Mendoza and Dr. Rodriguez. Let's give them again a strong hand of applause. I'm like many of you in this room, I don't have a clinical background per se, but I do have the advantage of being with the two of them in meetings. And I think it's Thursday, we have the valve clinic, and I, of course, sit against the wall. You know, I'm not a physician, I don't have a seat at the table, but I see both of them with their colleagues, and there's probably about 20 in the room, and they're looking at various case presentations, patients, and collectively they make decisions. But it all starts with the work that Dr. Mendoza and Dr. Rodriguez present, because it is the imaging that really highlights what the challenges are, what's going on within that heart, so everyone else in that room can view. And of course, they look at other factors and collectively make decisions, but it's really fascinating. So thank you both for sharing tonight. And so now we're gonna have Q&A. And so because we do have people online virtually, unfortunately, just raise your hand. I'll give you the microphone if you don't mind speaking into the microphone, so our friends online can hear as well. And then both Dr. Mendoza and Rodriguez will answer our questions. So I saw a gentleman, if you don't mind, I'll go right here first.
Yeah, my question is, what causes AFib?
What causes AFib? Why don't you talk in that mic?
So, Can you guys hear me? Okay, yeah. So this is how I tell my patients about AFib. So you see the heart as a house, right? Inside of the house, there's always wiring. As we age, it's been beating since we're 0 years old, right? As we age, the wiring in the house might get a little funky sometimes, right? It might get expanded, it might get short-circuited. So age is a risk factor for having atrial fibrillation just because the heart is kind of enlarging as we age. Women have a higher risk of having atrial fibrillation. Actually, I don't know the reason, but they are at higher risk, as well as patients who are more obese and alcohol. So anything that kind of makes your wires go J-wire, obesity, alcohol, just give you more risk factors for atrial fibrillation. Or if you're having some sort of infection, all of it can trigger the arrhythmia.
Thank
Function of the heart, the valves opening, closing, and all, that's based on electrical signals, right?
Well, the opening and closing of the valves is more a pressure-based system, but the electrical system is keeping the heart contracting, yes.
Okay, thank you. I'm sorry.
Oh.
Why don't we just keep going? We get to, because we have a lot of people that want to ask questions. If you don't mind, sir.
You can,
Okay.
let's give everyone a few. You can ask after. We'll swing that. Okay.
Okay.
Thank you.
Hi, thank you both. Dr. Mendoza, you did mention having an Apple Watch and your iPhone, and you could check it and it would tell you if you're in AFib.
Yep.
So what do you do when you check it and you are in AFib? Do you take a deep plunge in a nice cold bath? Or exactly what's the remedy for,
Sure.
taking care of that at the moment?
Yeah, I mean, so two things. I mean, it really comes down to, do you already have AFib or not, right? Or is it detecting it for the first time, right? So if it's detecting it for the first time and it's not bothering you, then you don't have to do anything, okay? Like I said, some people don't feel it when they're in AFib at all. It's amazing how the same condition, some people can be clueless that they have it, and some people feel like they're dying, right? And so if it's not bothering you, then you basically the next day, don't call your doctor at 2 in the morning if it alerts you at 2 in the morning. You can just tell us the next day, okay? And then we'll have the conversation. When somebody has AFib, we try to calculate their risk of having a stroke, and depending on their risk of having a stroke, we may need to do an aspirin or a stronger blood thinner, or may not need to do anything about it, okay? So that's number one. Obviously, if you have an AFib and your watch tells you and you're feeling really super short of breath, or you feel like you're gonna faint, then yeah, you get your tushy in the emergency room, right? Okay, so really the symptoms are the main driver in terms of what you do at that moment, okay? If you already have AFib and it's just telling you, and then I don't use the watch as much if you've already been diagnosed with AFib. To me, the most important part of the Apple Watch is it's gonna diagnose a lot of people with AFib before they would otherwise know it, okay? Like, I mean, I'll give you a sad story. I mean, maybe a few years back, I saw a lady who came into the hospital with a stroke, and a week prior, she had seen her primary care doctor for her annual checkup, and a week later, she started having palpitations, and she called her primary care doctor to get an appointment. They said, well, we just saw her. So they put her down an appointment for a month later, and then 2 days later, she had a stroke, right? If she had her Apple Watch, we could have started her on the blood thinner and prevented the stroke, right? So that's the Apple Watch will definitely save lives and definitely prevent strokes. And like I said, it's not just Apple Watch. I don't want to be specific to one company, but yeah, Fitbit does it, the Aura Watch does it, those things like that. Yeah.
Thank you.
I've got two really quick questions. One is, how fast does heart disease develop over your lifetime? How fast or how slow does it develop? And then two, can you actually turn it around? I mean, do you just stop it from getting worse? Or can you actually, through diet, exercise, kind of help clear up some of the problems in your heart?
I can take it, yeah. Yeah, everybody who comes to the hospital and has a heart attack tells me, but wait, I started eating veggies last week. Like, what happened? I'm like, It's not. That's a great question, is what I want to say. So, coronary artery disease, or the development of plaque in your arteries. And remember, we have arteries not only in our heart, we have them in our brain, everywhere, right? Everywhere where we get oxygen, we have arteries. So this happens everywhere in our body. It takes decades. It starts, I think, in our late 20s, things that happen, but usually when patients are like in their 40s or 30s, if we do one of these coronary angiograms, the likelihood of having coronary artery disease is extremely low. So I would say the development of plaque, to an extent, really I see it more in the 50s, depending on your lifestyle. Of course, if you've had a healthy lifestyle, you might not have anything, but it takes decades to develop throughout your body. And then, yes, once you have the plaque, what do you do about it? Thankfully, sometimes when we add statins, or when people have gone into vegan diets, very extreme anti-inflammatory kind of measures, you can regress the plaque. And we've seen that in some studies, thankfully. So, especially soft plaque. Once it's hardened, like the calcium that I showed you guys, it's like the kitchen pipe. It's really hard to scrape off. You're not going to be able to take that off. But if it's soft, it might get better and regress. So there's hope. Yeah.
Thank you. Any questions over on this side? Okay. Hold on, let me get this gentleman in the front.
Me? No. I have three. One is, what's your definition of high blood pressure? Is it the active blood pressure or the resting blood pressure? Because in the morning, before I had some medication, my blood pressure was 150, 160. And after some medication, it's now around 140. But after taking about 5 or 6 or 7 measurements, it goes down to 130, and then sometimes down to 120. So what really is blood pressure?
Okay, so that's it? Those are your questions?
I've got 2 more questions.
Okay, you want to just sit, is he allowed to have 2 more questions, or? Okay, go ahead and start, and I'll, depending on how long they answer. But go ahead, ask them all, and then we'll go through 4.
Okay, the other one is, how bad is sugar and salt on the heart?
Okay, that's 2, and number 3?
Number 3 is, how does Kaiser Permanente's imaging capability compare to your capability?
All right. I'll put number 3 to the...
Ours is better.
So I'll take one. So, I mean, blood pressure is tricky, to be honest with you. Because, what you get in my office may be different than what you get at your house, and maybe different than what you get at 8 in the morning versus 8 p.m., right? And if you check it with your arm like this, or you check it on the table, resting on the table, right? So we usually say it's the resting one that matters. And there was a recent article that showed that if you rest it on the table instead of just letting it hang, it's usually like 10 points later. So rest it on the table about heart height, okay? And that'll be the most accurate, okay? But even with that, I mean, if you check it 10 times a day, it's gonna be all over the place, right? So that's why I tend to look at average, okay? So somebody who I'm not sure whether I need to treat their blood pressure or not, I'll have them check it, like I'll say, hey, a week before you come and see me, check it twice a day, bring it on a piece of paper just for the 7 days before you see me, so I can look to see the average. Because you're gonna have some 140s sometimes, and you may have some 150, but you may have some 110s, right? There actually are conditions where people can literally be 180. There's a condition called autonomic disorder where you're 180, and then 2 hours later, you're 75, okay? And so that's why looking at the average is really helpful. We're getting a little bit more aggressive with blood pressure. It used to be we only treated people if they were over 140, but there's more and more data that we probably should be keeping people under 130, okay? Not just for prevention of heart disease, but there's been accumulation of data over the last 5 years that one common cause of dementia is just very mild low blood pressure. So if you look at people who have blood pressures in their 120s versus 130s, the 120s are more likely to preserve their memory than the 130s. So it's not just for heart purposes.
I will add something to that. Exercise, it will increase your blood pressure. I mean, you're exercising. What is abnormal blood pressure when you're exercising? We generally define it as like 200 and something, 220, I think, something like that in men, and 190 for women. So that's kind of how we detect high blood pressure while you're exercising, which is something that we test sometimes during the treadmill stress test.
Okay, thank you.
Oh, the sugar and salt.
If you don't eat any sugar, you're going to die. So you got to eat some sugar, but you just, like most things, it has to be right? So, yeah, it has to be in moderation, right? And it depends on your disease, right? If you have diabetes, you can't eat as much sugar as a regular person. If you don't have diabetes, you can get away with more. Same thing with salt. If you have congestive heart failure, you better not eat a lot of salt because you're going to get congestive heart failure. If you don't, you can probably eat a little more, right? But both of those things are critical things that your body cannot live without.
Right, but we generally recommend less than 2 grams of salt for patients who have high blood pressure. So less than 2 grams of salt per day is what you're supposed to do.
Dr. Mendoza, you had said something about muscle pain for patients who take statins. Is there something which you can do to not have the pain or to prevent it?
Is that it? You can finish if you have more.
And for blood pressure, is there a normal for, depending on your age also? Because I believe that when you're much older, the difficulty to get your blood pressure down to 120/80 is almost like impossible.
Yeah.
And you try hard and it just doesn't happen that way. So what would be you already answered this question. But
Yeah, I
what would
mean,
it be?
answering it from a scientific standpoint, we still kind of use the same cutoff no matter what age you are. It is definitely true that the older you are, the more likely you are to have high blood pressure. But as we learned over the years, I mean, it used to be back in like the 70s, we were like trying to get people's blood pressures under 160, right? Because the idea was, it's normal for people in their 70s to have 160s, right? And then they did studies and they looked to see, well, do people who have between 140 and 160 do better than the people between 160 and 170? And they did, right? And so every few decades they do studies and it turns out the better, right? Now, obviously too low, we don't want you too low because then you get dizzy and lightheaded and all those things, right? So we still try to get you as low as we can on the blood pressure part. There are a lot of medicines that we can do out there, keeping your salt level low, keeping your weight down, exercising, all those things kind of keep it down as well. On the cholesterol medicine side, there are people like if you have low vitamin D, you're more prone to get muscle aches from the statins. So if that's one thing. Some people take coenzyme Q10. Some people that helps eradicate the muscles. But I think the main thing is we're in 2024, right? There's a lot of medicines out there, right? So, as a cardiologist, the one thing I like about my field is if I give you a medicine and it causes a side effect, I don't want you to have a side effect, right? You need to tell me, and my job then is to find something for you that won't give you any side effect, okay? I'm not a cancer doctor where I have to say, you know what? This chemo is going to be really tough on you, but this is the only way to go through it, right? If you try hard enough, you can find meds that don't cause side effects. You just have to go through the process. So sometimes just trying a different statin, or like I said, one of the non-statins if you keep having muscle aches.
Thank you. Hold on.
Good evening, both doctors. That was a great presentation, by the way. I come from a high blood pressure family, but I'm pretty active. Is there something I need to be really concerned about? I'm 52. I just want to make sure I'm on the right path. And the other question is, do you guys accept new patients? Because I have a doctor in UCLA, quite a distance from Cerritos for me to make the drive if something happens. So I just want to see if you guys are accepting new patients as well.
I'm accepting new patients. I'm sure you are too, right? Maybe?
They tend to get punted.
Okay, so I can see you. So for you specifically and your risk factors, if you would come to my office, I think the biggest risk factor that I look for is not only high blood pressure, because that is really lifestyle driven. What you eat is what you are. I think more than anything is if they had a heart attack before their 50s and 40s, I would be very aggressive in knowing, first of all, your age. If you're more than 35, we recommend a lipid panel just to know your baseline, and that will change with whatever diet, and as time goes by. Women, when we hit menopause, our metabolism changes, and that might change as well. So, we would start with some basic testing and kind of risk stratification, and getting to know what your exercise profile is kind of how I generally go about young patients, and your weight, know what you're doing every day, and kind of what you're eating. So I take a really big preventive kind of strategy, especially with my younger patients, and then I kind of guide them through it based on what we get. Then we can discuss kind of things moving forward, like exercise routines. It's a lot of coaching in cardiology. It's a lot of prevention. So that's how I would go about kind of preventing you from having high blood pressure. I think the key is, as we've said time and time again, exercising and finding. And what I say to my patients, and this is for all of you, not every exercise is for everybody. You're going to have to find your groove. What's the thing that you like to do? And then you won't be doing that every day. Just start 15 minutes, start very small things and set expectations for yourself that are realistic. Like, can I actually wake up at 6:30 a.m.? Then if the answer is no, and to do a little bit of exercise, then do it in the afternoon, just a little bit, instead of watching TV for 3 hours or something like that. We all do it, it's okay. So, it's kind of adjusting your expectations and taking it slow so it's a marathon, not a sprint, so you can have something that you like, that you will do consistently. I think that's the key to keeping you out of high blood pressure. Yeah.
Thank you.
Yeah.
We have a question online. This individual is asking about, they've had some different tests and the results are a little bit different, and so she's wondering why they're differentiating. She had a chest CT and it showed severe artery calcification. She had a CT angiogram 18 months ago which showed 50% stenosis, and her cardiac cath was done 6 months ago and it showed 40% stenosis. Why are these results, what differentiates them, and what are the margins of error and strengths and weaknesses of each of these tests?
Yeah, what a great question. So when I report stenoses, it's hard for me in coronary CT, it's hard for me to put in a number. That's why I always report in ranges. Why? Because I'm being really bold if I say, this is the amount of stenosis, So I think that's keeping the margin of error, for example, for me, is reporting less than 25%, 25 to 49%, 49, 50 to 69, right? That's my margin of error. I don't want to be, sometimes I do it less if I'm getting more confident. I decrease the range, but it will depend on the reader. 50% is just telling you that you have non-obstructive disease, and that's kind of the message that you need to receive out of this, versus your cath that maybe showed a 40% stenosis. It's just a 10% difference. It's not a big deal. We're just telling you that you have non-obstructive disease and you might want to do something about it in the future, and all these lifestyle changes get you on a statin, perhaps on aspirin and stuff like that, to prevent that from getting to a heart attack.
Thank you. I think we had a question here. Yes.
Earlier in the slides, you mentioned preeclampsia, and it seems that there has been an increase from what I've read of postpartum preeclampsia, and it has arrived in our family recently. And I'm wondering what a young woman, what she does with that after birth. And in this case, our daughter has a congenital heart disease, bicuspid aortic valve, and is that a complication?
Sure.
Yeah.
So I'm going to take the bicuspid valve out of it first, okay? But so yeah, let's say you have preeclampsia. That increases your lifetime risk, okay? If if you have preeclampsia, that means you just had a baby. Your odds of having heart disease in the next decade or two is still very, very, very low. But I would keep that in your mind, right? So that later on, as you get closer where you might want to start thinking about, I would say, first thing I would do is I would take that internally and say, I just got one risk factor, right? I better do a little bit more diet and exercise if I'm not doing that already. Maybe that'd be a motivating factor for me to do a little more than what I'm doing already, number one, okay? But then number two, I'm gonna look at that as later on and say, if somebody's like on the fence of like, I don't know whether to put you on a cholesterol pill or not, maybe that's the hedge to say, yes, I should, because you're kind of on the fence. That won't tip you over kind of thing. You got it? So your risk is a little bit higher than would otherwise be calculated. No, but again, cholesterol is a risk factor for heart disease, and you already have another one, so you got it? Okay, perfect.
Okay. Thank you. Sir?
I'm over here. This is a cholesterol question. A lot of people in this room have the home blood pressure test machines. My blood pressure is not particularly high, but they don't like my ratios of LDLs to HDLs, and I've been putting off going into a medicine for it, and I'd like to do a lifestyle change. The question is, those home cholesterol tests, are they accurate? And if I were to use that to metric myself for improvement, or do I need to go on medicine? How do you recommend the home cholesterol testers?
You want that one or yeah?
I mean, I don't know anything about the home cholesterol test. Do you know something about that?
I honestly, I don't know anything about the home cholesterol testers. I don't know, whether they're, how accurate they are, reliable they are, right? Things like that, right? So that's number one. But I mean, I think, like I said, if you have cholesterol, your ratio is not great, and maybe you're a good guy for a coronary calcium scan to look to see how much disease you have in your arteries, right? Because if you don't have any heart disease in your arteries and it's completely zero, then I would agree with you. You don't need a medicine for that, right? But if your amount of plaque that you have is through the roof, you better do something soon, right? Okay.
Yeah, Dr. Mendoza, you mentioned the vitamin D and CoQ10 for one of your patients. Almost every supplement says it's a heart-healthy supplement. Are there supplements everyone should be taking, or are there just supplements certain patients should be taking in certain situations?
You want that one or you want
I think he asked.
Okay. Try to get out of that one. No, it's good. I don't know anything that you have to take, right? So, I mean, I think vitamin D tends to be a common one because if you actually test people for vitamin D, the prevalence, so how often people have low vitamin D, it's pretty high, right? Why? Because your body makes vitamin D in response to the sun it gets, right? But most of us nowadays, when we go in the sun, we lather ourselves up with sunblock, right? So we're blocking the sun's ability to tell our body, hey, make vitamin D, right? And then, unfortunately, the culture of today's era is a lot of people are indoors working. It's not, 200 years ago where people were working out in the fields and things like that. So for both reasons, vitamin D tends to be low. But I'm not telling you that because there's data that says, oh, if you do vitamin D, you're going to prevent this and this and this and that. That level of scientific research, clinical trials, hasn't really been there, my standing for most of the supplements. So if we're doing it, it's more to, hey, try to see if this helps my symptoms out, right? Just like the same thing, there's medicines for joints that some people, supplements that sometimes they help and sometimes they don't, right? Something like that. You're doing it in those cases for symptoms, not for prevention of some major disease. Not to my knowledge, yeah.
I've been on vitamin D for years because my doctor recommended it early on. But I've read that vitamin D can increase calcium buildup as well.
Yeah, good question. So the calcium that you eat or the vitamin D doesn't correlate with the calcium you put in your arteries, right? Okay. So sometimes people get asked that, oh shoot, I got a lot of calcium, coronary calcium. Should I stop taking my calcium? That's the calcium that's in the arteries is because you have inflammation in the arteries, and then your body's trying to attack the cholesterol and the inflammation in there, and it releases calcium in there. Right? So it's not correlated with how much you eat.
Thank you. We have a question over here.
Dr. Ruiz, you mentioned that a plaque screen or analysis, do you do that at Memorial or it's coming?
Coming soon. But yeah, we will be doing that. Yeah.
How soon is soon? I believe
Rose knows. I don't know.
Yeah, I think it's going to be finalized this month, And then we will have to, I would say January,
Yeah.
February, yeah.
It's a New Year's gift for you.
Yeah, it's New Year's gift.
What is the additional value of that?
Of plaque analysis? Yeah, so I think sometimes with, as you saw with my naked eye, I'm not AI, you know, I can miss some volume of plaque perhaps, and that might detect a little bit more plaque, and it might help us as clinician be more aggressive. And by that I mean, for, you know, in your case, high cholesterol or your ratio, we might be like, okay, we need to lower it less than 70 because we have this amount of plaque in your arteries, and we want to be as aggressive as we can be with what we know accumulates in the heart arteries, right, which is LDL cholesterol. And so that's how we would kind of cater to that situation. We would either add aspirin for primary prevention to keep your blood flow nice and, you know, smooth, or we would be more aggressive with cholesterol management. Yeah.
So that'll be a differentiator, right? So when you get your CAT scan at Memorial, it'll have that in it, whereas if you're going to another place, you won't get that with it. Right? So it would be a differentiator. Most places don't have that.
Right. We have a question over here, ma'am.
I was in the hospital in June with AFib for the first time because I had pneumonia. That's probably what caused it. But I still have shortness of breath. What's going on?
You want that one?
Yeah, I mean, that's tough because shortness of breath is a word that has such a big differential. And in pneumonia, some people have permanent changes to their lung tissue depending on the kind of pneumonia that you had. And so it takes a team effort to kind of solve that one. And I do think the team involves a cardiologist, yes. So with risk factors such as you having had atrial fibrillation, I would, you know, come take a visit or a referral to one of us, and so we can further explore what that shortness of breath, the nature of the shortness of breath, when it's coming on, and explore, you know, what's the cause. Usually the workup for that is a sonogram of the heart, and maybe some stress testing, depending on the conversation that you have with your cardiologist. Yeah.
Thank you. We have another question in the back.
For high triglycerides, do you recommend a statin or a non-statin? If overall cholesterol's
triglycerides are tricky, right? So there's two general strategies with triglycerides, right? So it kind of depends on how high it is, number one, right? So if you're very high, like in the 300s or 500s, there's a risk of pancreatitis and like fatty liver and a bunch of other things. So in those cases, you would want to treat the triglycerides just to prevent the pancreatitis or the liver issue, right? Okay. The statins don't really lower the triglycerides, okay? So one strategy, let's say if your triglycerides aren't too high and you have risk factors for heart disease and your doctor doesn't like your triglycerides being so high, one strategy is to say, hey, we'll go ahead and try treating your triglycerides to get them down. But the other strategy is going to say, well, you know, look, there's not as great medicines for triglycerides as there is for treating your LDL, okay? So I'm going to let you have high triglycerides, but I'm going to get your LDL really low to offset for the high triglycerides. Those are the kind of the strategies, and those are typically, you know, these things are individualized per person. Okay.
I will add something to that. Usually when your triglycerides are high, I look at if the patient is pre-diabetic or diabetic. If you're eating a lot of carbs, that usually, if you cut the carbs, that'll usually decrease your triglycerides. So, you know, I look at that and say, okay, we can manage carb loading, less carbs, and that usually might also a good strategy in terms of medication is omega-3 fatty acids. So omega-3s are good anti-inflammatory, and they will generally reduce triglycerides, not as in a potent fashion as another medication that we have that is called Vascepa, that is for when patients have heart attacks and they have more than 150 of triglycerides, we want to reduce them with that medication. So it depends, like Dr. Mendoza said, on the kind of scenario.
Thank you. Sorry, you had your arm up?
Hello, two somewhat interrelated questions. I know a number of friends that have had health problems, but they're of the age like where family history is unknown. Is there anything that's available now that sort of indicates what kind of problems might be actually inherited that you can't do anything about? Because like a friend of mine went to the doctor. His cholesterols were off the chart, his cholesterol levels. So he cut out dairy, but it didn't really improve his health. And then the second question is, how do you know that the AI models that you're using are really accurate enough as a source?
AI models.
AI
How do you know it?
Oh, yeah, good question. Okay, I'll tack that one because I actually forgot the first question. But okay, AI models. So those models they are fed thousands of coronary CTs, just like every neural link. And these might be big words for all of us because we're all learning about AI. So they are fed into a model. All of these abnormal CT scans, all of these normal CT scans. From multiple universities. Correct. Multiple universities, so it gets a huge amount of data that it encompasses and studies, and so it gets more accurate with more numbers. And so that's how we have studies that have validated the ischemic evaluation, and we're getting a little bit more. The plaque analysis isn't as good as it might be at this moment. We're still tweaking it, to be honest. We're still working on it, but from a scientific standpoint. But yeah, AI for ischemia analysis is pretty accurate right now. And the other question was
Genetics.
Oh yeah, we have genetic testing. It's called Lp(a). It should be done at least once in your lifetime, generally recommended for patients that are younger that come to my clinic, because once we hit 60s or 70s, there's so much that we did already in terms of eating or not exercise that, sort of like the damage might be done at that point, and then their family history you made it to 70 or 60, that's great, we're good. So it's more of questions for patients who are 40, early 30s, some sort of like that. But Lp(a) is a good genetic marker for disease that you might have inherited, and we're working on medications actually now to decrease Lp(a). Right now, there's nothing in the market, but as a society, we're working on that.
Yeah, I'll just expand on it. There's some rare conditions where there's specific DNA mutations that are hard, like if you have hypertrophic cardiomyopathy. She showed us a case of arrhythmic right ventricular dysplasia, where there's a specific gene for that, right? So for those kinds of things there are, insurance little by little is starting to do more approval. Like one of the more common ones I see is aneurysms of the aorta, right? So that's a very common entity. There are genetics that you can check for stuff like that, right? So, but usually we don't just blindly just check your DNA, test me for every single, what things may I develop at some point in my life. We're not there yet. I think they need to get the cost of the stuff down. There are things you can do there are these other companies like 23andMe and other things where you do your DNA and they do some assessment of it, right?
23andMe got busted.
Yes, they did. So that's why I said that one with some hesitation, because they can get hacked, right? But yeah, I did want to put that out there. I forgot to answer your question on the bicuspid valve. So if you have preeclampsia, you're more likely to have high blood pressure later in life. And with bicuspid valve, you're more prone to have an aneurysm of your aorta, right? And one of the causes that makes your aorta bigger or more aneurysm is high blood pressure, right? So the main thing will be just keeping a good eye on her blood pressure, okay?
Thank you, everyone. You guys, it's 7 o'clock. So I want to be cognizant of your time, and if you choose to leave, feel free to do so. Our physicians and speakers are willing to stay a little bit afterwards. Sir, I know you've got a question up there in the front. But feel free, and please take the time to do our survey. Just scan on that QRC code. We really value your feedback because that is what impacts our future programs. So Dr. Mendoza and Dr. Rodriguez, thank you so much for being here this evening.